Lovely to see you all tonight, and we'll go for it. So I was asked to do a topic on pelvic floor SOS, and I guess that was the idea was to focus on what we can do, and maybe at this time when we can't see our full medical team or surgery might not be the option, but also I think these things are valid at any point in time. And I'm just going to stop there and unshare the screen, because when I'm sharing, I can't see everybody, and I'm just checking in to see that everyone can still see me. Is that correct? Yep, and you can see the screen? Look like a PowerPoint?
Yep.
Brilliant. Okay, fabulous. All right, thanks. Technology is yet. Let's go back a step. So, oh, there we go. Buttons coming up. Share again. So I'll come back if I need to, and I did try and include some points where we can talk a little bit, but we'll go from here and start in the beginning. So first of all, I think, as I said, pelvic floor SOS, and we'll go from there. So really, I think it needs to be said that at any point, the foundations are really important. You know, whether it's the worst flare you've had, the best time you're having, that you can do the little things and the little drugs on top, or the little cute exercise programs that are given to you, but the foundations are the ones to get right. So I'm going to start on the side of knowledge, and then we're going to go through some of these things and really piece them out a little bit more. So knowledge to me is really, really important. And some of you that have seen a physio, this should be commonplace, but I also wanted to go through it with you, just so you have an idea about things in the pelvis, because I think this is something that's overlooked a little bit as well. So I'm just going to use my highlighter here. And what you've got here is a hemipelvis. So it's chopped down the middle. You've got your pubic bone here at the front. You've got the edge of your sacrum and your tailbone here. And this big piece of pink stuff that comes all the way from your tailbone out to your hip here is the area of the pelvic floor. Now, to take it back a step, you've also got this big yellow section at the back here, which is the group of what we call sacral nerves. Now, because they come out of the sacral bone. Now, those sacral nerves are responsible for every message that comes in and out of your pelvis. So whether we're talking about endometrial deposits growing somewhere within the pelvis and they're inflamed and cranky, if we're talking about ovulation, we're talking about your bladder urge and whether it's strong or just normal, whether you're constipated or have IBS symptoms, all the muscles of the pelvis, or even to the level of the skin. It all goes to and from this nervous system. And I think that's really important to note as we build onto it, that the nerves are responsible to how these messages are processed. So the muscles of our body, the skin, every input we get doesn't get past this computer stage. Now, we do know more recently, and as we build on our pain knowledge, that it is this nervous system that drives our pain protection. So it at the spinal cord level and at the local level of just those little nerve endings, it can produce an inflammatory response. Now, that inflammatory response leads to more messages, more sensations, more protective mechanisms, whether it be the bladder or the bowel or the pelvic floor muscles. Now, in this picture as well, we've got that big nerve, and you can see the bit of it in the middle is actually the sciatic nerve. At the back, you've got your glute muscles. In particular, that's a muscle called piriformis, and then the pelvic floor is on the other side. So when you think you are having these weird symptoms and your pain is referring down your legs or into your lower back, it is quite common that these nerves are inflamed and cranky. They're getting cross messages. So it is a very normal pattern to see that referral of pain out of, well, why is it just, my ovary that's cranky and I'm getting pain everywhere? So I really want to make sure that you understand that knowledge gives you power. And you understand that just because my pain isn't located where my surgery was or what's going on, it is still integrated into your pelvis. Now, as I mentioned, this line here is the pelvic floor. This muscle on the wall here, and I've just lost my highlighter, This one is a bit of a bane of my existence, which is called obturator internus. And you can see it attaches onto the pelvic floor. Now that often refers up into the lower abdomen. And so pain isn't just always the pelvic floor, but these two work very closely together. As you can see, if I get rid of some of that highlighting, that where we've got that underneath, you can see it's coming down into the rectum here. This is the entrance to the vagina, and then your bladder at the front. So these muscles are really important for all of those. So a quick refresh, but really important. If you know your anatomy, it's more complicated, unfortunately, than just, oh, it's just a little muscle. It's the muscle and the nervous system. Now, when we look at the muscles, if I'm just going to the next slide. Sorry, everyone. It's deciding that that's not a great idea. There we go. That pelvic floor symptoms, well, it can't just be my muscles. When we see patients, and I say we, as I've worked in multidisciplinary teams for quite some time, that the pelvic floor is likely to be responsible for a lot of the symptoms that we're getting. And as I said, I think it feeds back into the nervous system at many levels. The severe pain flares seem to be related, and I say seem because I'll come into some of the evidence later, to a lot of mechanical change in the pelvic floor. So severe pain flares on top of already other symptoms can be a contributor to pelvic floor muscle spasm. But a lot of people, and you know, unless you've got a really good team, they might not have even talked to you about this or covered the fact that there is pelvic floor involvement as well. Now, as I mentioned, you can't really do a wee or a poo or have intercourse without these muscles having a role with those. So if your pelvic floor is not working properly, then you will have changes to voiding or weeing. And I've put the terms in there on purpose, and I usually say wee and poo, but you'll often hear doctors, and I'll get a lot of patients and they'll come in and say, I've been diagnosed with vaginismus. And I'm like, well, that's really good. That means muscle spasm of your pelvic floor. And that even just is calming in itself. But I've put the terms in there so you'll hear them, you'll read them, and that way they'll make sense as we go through them. So voiding dysfunction, most commonly when we've got overactive tense muscles, they've got a slow stream, there's urgency, there's incomplete emptying. Obstructive defecation means problems pooing. So straining, constipation, prolapse, and I am talking more rectal prolapse than vaginal prolapse. But if you strain for long enough, it does stretch the fascial support or the other support structures of the rectum, and it can work its way down. And that's a really good sign of long-term dysfunction. It doesn't happen overnight. Because of all of the symptoms I've mentioned, you develop urgency. It's both sensory, so it feeds directly into that nervous system, but it can then relate to also tightness, inflammation of the muscles. The skin can become quite sensitive. You can get little cuts because you're straining or constipated, and that ramps up that urgency again. And we do know that if you're looking at the back passage, which is the muscles right at the back door, they're kind of the boss of that whole conveyor belt. So if they're telling everyone to slow down or they're not working when they should be, that you can get a ramp up of your IBS symptoms. So further back up the chain, bloating, irritable with foods, more irritable and cramping behaviors because it just doesn't move very well. So one end talks to the other. As I said, fancy terms here, dyspareunia and vaginismus, painful intercourse or pelvic floor spasm. Vulvodynia means pain of the vulva, so the outer part of the vagina, the skin as you open it. Now that can be provoked or unprovoked, and that's really due to, you know, vulvodynia is almost contributing to a pelvic floor factor. I mentioned here amplified dysmenorrhea. Now dysmenorrhea is the word for painful periods. I wrote amplified because you can have painful periods and a normal pelvic floor. But I always see that if your pelvic floor is worse, then period pain will be worse as well. So I'm not saying it's just because of pelvic floor, but definitely we know that treatments of pelvic floor are some of the best for reducing pain during a period. So the best evidence we have is in what we call primary dysmenorrhea or primary painful periods. So these were the studies done for women that didn't have endo, and actually 40% of women under a laparoscopic investigation don't have endometriosis, but severe painful periods. It was shown that pelvic floor movement and things like exercise and timing of exercise and yoga and stretches actually reduce the duration and intensity of pain. So they're in your toolkit. They have no side effects. We can add them in quite safely. Pelvic girdle pain, and I'm going to skip back to that last picture we had, and I kind of took you out of the pelvis or out of the pelvic floor a little bit and showed you that there are the other muscles of the pelvis. So the sacrum, which is that bony part at the back, if we highlight again, this part here has the glutes on the outside. Here is our hip muscles. Here is the pelvic floor. They all work together. You can't have one working well and the others all being perfectly normal as well. It's generally, if one's not working, you will pick up on changes. So it's quite common that then you have pelvic floor dysfunction, you can have changes in how your glutes turn on, and then it's a battle of, well, where do we start? Is it the glutes that we start with or the pelvic floor? Okay. Vaginal pain and rectal pain, and I think this is a really good contributor of pelvic floor dysfunction because there's not much else right down low at that entrance that if you're getting shooting rectal pain or vaginal pain, it's a really good sign that those muscles aren't moving as well as they can. And as I showed you with the nervous system, that lower abdominal pain and that lower back pain can be part of it because the nervous system can contribute to the whole area. So just because it's not at the vagina, it doesn't mean it's not those muscles. Now I put in big brackets over here, that 80 to 90%, and that's because that's what we know of the studies we have in endometriosis and primary dysmenorrhea, that there is dysfunction in the muscles of the pelvis. So pelvic floor and obturator internus are not working effectively in 80 to 90% of people. So that's a bit of knowledge. I've done that first pillar. You know, we could spend hours talking on that, but I want to make sure we're moving on to some of the practical things as well. Now, rising stress can become distress itself. So calming the mind is really about targeting that nervous system. If it's running on high altitude, and I think of it like the surging power cord, all of those structures are going to be high on edge too. So one of my first strategies I talk through with people is about daily checking in or body scanning. So as part of addressing pelvic floor, breathing is my first strategy. So when we look at body scanning, I'm talking 3 to 4 times a day, checking in and going, well, what am I doing? Because these structures do it in 80 to 90% of people, they do it all the time. It's not just when you have a flare that these symptoms are there. It's just that they're not on the radar when you're having a good day or you're busy elsewhere. So check in, you know, a minute at a time. How am I breathing? What is my pelvic floor doing? Or what are my hips doing? Am I, you know, really scrunched in and everything's really tight? And can I change it? So we're going to go through this a little bit, and addressing breathing patterns really helps to try and unwind that nervous system a little bit, okay? There are strategies that you can use. I've mentioned some of them there. So there's the Calm app, which actually has a breathing button. Insight Timer, it's just got lots of options. So there's no perfect apps for every person. And there's also lots of relaxation audios or visuals out there. Some are good, some don't work for everyone, and that's perfectly fine. There's no research to say one is better than the other. But finding something that helps you center or relax that breathing down into the tummy is really important. Now, before I flick back so you can see me as well, I'm just going to show you what I mean by breathing. Now, oh, that's annoying. That's from the last slide, isn't it? So if we clear that, cool. So what we can see here is this is the level of the diaphragm. All right. In this picture, it's up the top. And down the bottom, we have our pelvic floor, and we're going to practice this. The big yellow thing that's coming down through here is what we call the vagus nerve. And you can see it actually has big innervations to the gut and to the stomach, to the heart, and then straight up to the brain. Now, the diaphragm is able to regulate that nerve. So as you use your diaphragm to breathe, and it is possible to breathe without it, it regulates down the nervous system. So it's turning off that fight or flight pattern, okay? So I'm going to stop sharing here, and we're actually going to practice it. Okay. So let's go to some of our videos, and I'll get you all up. So far, was that okay? We all saw the slides? Yep, cool. All right. In a minute, we will stop and have a bit of a question. So far you can see me. I'm going to sit side on, okay? I want you, whether you're sitting or lying, wherever you feel comfortable, you can pop one hand on your tummy and one hand on your chest. And whether I see you or not, completely up to you. But I want everyone to close their eyes for me, okay? So when you're ready, what I want you to do is we're going to take 3 or 4 breaths. And it is harder in sitting. So some of you I saw were very comfy in bed. So you might want to do this lying on your back or on your side. But I just want you to take a deep breath in. And as you breathe in, and then breathe out, I want you to note, okay, which hand is doing more movement? Is it my upper chest? Are my shoulders coming up towards my ears? Or is my diaphragm and my ribs moving in and out more? Now, granted, when we're sitting, we do get more upper chest movement because we're upright. So we're using our abdominals to keep us upright. But generally, in a relaxed breathing state, and this is what we check in with a few times a day when we're body scanning, we want the breathing to come from down here. So how do we get it? Most of you might have felt it was up here. I could actually see some of you were a bit more dominant, and I can see some of you nodding as well, because they were the ones I'm going, yep, that one and that one. So what I want to do, I'll give you a few cues. There's no perfect way to get it. It's about getting it. And if you're really struggling, my favorite is lying on your side, let your tummy hang out like Christmas, and breathe into that tummy, because sometimes sitting up is just too tricky. Now, I'm just going to pause before I show you some examples. How important is breathing? Have a think. Can we live without it? If we're in a pain state and our body is thinking we're under attack, is it going to like us messing with it? Probably not. It's going to go, no, that's enough. Breathing is really important. So trying to do this in a flare can be tricky. Getting in front of it, body scanning during the day, knowing that you've got these skills has to be practiced. Okay, so our first little skills that we can do, one easy one that you can do in any position, if you get a finger and a thumb, is alternate nasal breathing. Now, it looks a bit dumb, but it does actually, has been shown in some mindfulness studies to really help reduce it down. And you'll feel that straight away when you're doing it, you have to breathe a bit deeper. So you can turn your videos off if you don't look like a Gumby with me. But what we're going to do is just block one nostril. We're going to breathe in, swap, breathe out. Breathe in, swap back, breathe out. See if you can keep it going for a minute or two. And breathe out. Did you notice a change to breathing pattern? It came much lower. It had to slow down. And that's one way that if you're in a lot of pain, you focus on your fingers. It takes the focus away from your pelvis, away from your pain. It's something someone even can help you with, but it gives you a skill to try and break that breathing down. One other skill. So my other favorite is if you're lying in bed, you can have your favorite music on. We're really building a full toolkit of calming the mind, is thinking about where your jaw position is. Now, the analogy I use here is you can pick someone who's annoyed from a mile away. They're walking around like this. This is tense. This is what pain does to us. We want to see if we can drop that down so everything can volume back down again. So with our mouth, I want you to close your lips. It's hard to do when you're talking. Let your teeth drop away from each other. Gravity can assist to give that jaw some space. and rise your tongue up to the top of your mouth. What you'll find again is it's easier to breathe down in through your tummy as well. So these little cues again can be used during the day, but also during flares, so that pelvic floor SOS, when we're trying to get in front of it. Now, to take it a little bit further, if you want more tactile cueing, you can grab your shirt, so crossing your hands over, it gives you some resistance, and you can breathe down and in and breathing out. So we've given you 3 options. I want you to pick one. What we're going to do now is, because this isn't about breathing, and there's lots of good QENDO resources about breathing and yoga as well, and they cover it a lot, is I want to link that to pelvic floor. So with pelvic floor, as we breathe in, you saw that picture, diaphragm at the top, pelvic floor at the bottom. As we breathe in with our diaphragm, the pelvic floor is designed to lengthen. So it's not meant to just relax and drop, but it can feel like it's breathing too. And that's where we can get some movement of our pelvic floor by just taking those deep breaths in. So I did want to bring it back that I'm not just talking about breathing, but one works with the other. So as you find your best position, what I want you to do is just take a few breaths. We're going to feel that I can breathe down into my vagina. Think of it breathing, and see if that just gives that sort of pressure to let it go. It might go and straight back up again. Cool, that's what we've got to work on. But it might just help you feel that heaviness to let it go, to let it lengthen. Okay, so step number 1. To the slides now, if I can work out how to do that. No, it's not letting me go back. Sorry, everyone, technical on this end. It's just not letting me go back. There we go. Sorry, holding everyone up. Okay, so let's go back to those slides and keep moving. Okay, so some breathing skills there, calming the mind. Now, a big one here is to move. And yeah, as a physio, I'm talking about movement and exercise, and in this case, pelvic floor movement as well. Now, I won't go too much into these, but I wanted to give you some analogies of how muscles work. We've already talked about the anatomy of the pelvic floor, but what I also wanted to point out is that any muscle should be able to have good range of motion. So if you look at your hands, or you could use your toes, whichever one you want, and I want you to pick up a pen or something really light off the table. Now think about when you would use your hand in a more forceful example, like you were making a really strong fist or you're trying to lift something heavy. The level of activity in your hand is going to be really different. Now, while I talk on this slide, I want everyone to make a fist and hold it, okay? Because those muscles of your pelvic floor need to move. They need to turn on when you need them. So like every cough, stand, jump, lift, turn, they are active all the time. It's not like we can take them out of action, because you still need to wee and poo. But they're also meant to be able to turn on a little bit, you know, small amount if you get out of a chair, a large amount if you're vomiting, or jumping or doing CrossFit. So that is lost with overactive muscles. A muscle can be that's held on, can be really painful to touch. It doesn't have this beautiful fluid movement like picking up a pen and then lifting something heavy. And it can create both that dull ache sensation. And if it gets really cranky, we've all had a calf cramp. It's not a nice sensation, but it can come from the pelvic floor as well. Now think of back to that fist. How does it feel? It might be really tight. It might actually feel a bit swollen. And what's the one thing you all want to do is you want to get out and move those fingers. So very simply, movement is about getting the muscle to do what it can do. And physio, I guess, is trying to learn ways or keys or little cues into how to get that to move. And we're going to go through that as well. So my big secret with movement, and I use the word movement, not exercise, on purpose, but you don't need equipment, you don't need a mat, you don't need an EP. Sometimes it's very useful if we're talking pelvic and back pain, and you don't need a set routine. It can be little bits regularly that make a big difference, and it's about those pillars. So pelvic floor movements. We're going to go through some of these, and I'll come back to you live so you can see me, and also just some of the stretches that I like to incorporate into daily practice. Okay, so let's see if I can stop sharing that again. Hopefully we can come back to it as well. Okay, so everyone can still see me there? Good. So pelvic floor. I can't show you my pelvic floor, which is why they're where they are, but your pelvic floor muscles, one of the cues we can use is think about just closing the back passage. Okay, so you can all try that. It's that little lift and that drop back down. Okay, little close up, so you'll feel it lift from that muscle and then drop back down. See if we can time it with breathing. As you take your deep breath in, everything's relaxing. As you breathe out, hold your breath, try a little squeeze, let it go. Now I think of this like a jellyfish. It's a really gentle lift and it just drops back down. Now, not everyone can do a back passage cue. It does tend to be the most easy to get people to start to get the move. But the other cues I use is like stopping urine flow. It tends to be a bit more all or nothing. I guess because we don't slow our wheeze as much as we just close the back passage. So if you need to, try that cue. Try stop urine flow and then let it go. Little lift up and drop it down. Now what you should feel is that that muscle comes back to where it started, if not a little bit softer. A bit like shoulder shrugs. We don't do this with the shoulder shrug. We lift, we drop. And it actually feels a little bit looser. With pelvic floor and pelvic floor pain, that's what we're achieving. This is not a strength training exercise. So if you felt it went on, and that's where it is now, try just doing that breathing. Just pull it back down. See if the nervous system can tell that muscle, the diaphragm, to get it to passively stretch. Next time, try about 30%, 40% effort. Doesn't have to be more than that. It's more just that cue to lift and then drop it back down. The urine flow cue or the back passage cue can be one that might work better for you. What you could also think of is something sitting near the entrance of the vagina. I type to visualize like a pencil and see if you can draw it in and then let it go. So if we're struggling, and this is what I do all the time, is just trying to get a visual that matches those muscles best. Now, we don't always in a first session. Sometimes it does actually take a long time to relearn what these muscles are doing. Sometimes, like you noticed with your fist, if it's so tight and stuck, it's not just going to reopen and stretch and move really well. Sometimes we actually have to get rid of that stiffness a little bit first, and then you find it starts to have more range of motion. So always when I think of muscle stiffness or muscle activity, it's how stiff is it, how on is it? And it's always a combination. It depends on which way we go as to how we treat. So we've got urine flow, stop and let go. Vagina, draw up and let go. The other one I use is like those pickup machines, you know, gambling for kids. Pick up, let it go. Never really does a strong pickup. Or the back passage, lift and drop. Now I always combine with that slow breathing. And when muscles are slow to turn off, which is much more the example we're talking about here, is that you can really take 3 or 4 breaths in between just to see if that will help bring it back down. Okay. So pelvic floor can be used as a bit of a practice. We're not talking feedback here or stretching techniques, but we're just saying, okay, can I actually get this movement as part of body scanning, or if I'm resetting each day to see if I can drop that tone back down. The pelvic and back movements are more about the whole area starting to move. Now I'm going to do a little trick. We did the fist check before about just how sore muscles can get. I want you to all sit in your chairs, make everything as tight as you can, and then stand up. What you notice is that's really almost impossible. When we go to move, something has to turn off or lengthen to allow us to lean and then come back up and then relax back down. So body movements are always about this balance of what's on and what's off. So if we're getting the whole pelvis moving, it means that all of the friends of the pelvic floor are having to turn on and off, and that can actually help with some of that. So I'm going to bring me down onto the floor. Hopefully you can still hear me, but you'll definitely be able to see me move. And I'm just focusing on some of those movements that can help with that general tension. Okay, so coming over to here, generally you could even start in a standing position. If I come face on, I really like to see, can we actually get a pelvic circle? So rocking all the way around. Now, I can't see any of you, but I'm guessing none of you are doing it. But you can definitely try this. You could add hot water, you know, nice shower running on your back at the same time. You could just do forwards and back. I'll stand side on so you can see. It's a bit like twerking. So stick your bum under. If you imagine this is a fish bowl, we're tipping water out the front, and we're swishing water out the back, and then you can combine that around. Now in the middle of a flare, granted, standing freestanding, not going to be all that great. So you could be leaning on a bench doing this, as I said, on the wall of the shower, just to get some of that movement. Now one of my favorites as we come down here is even just getting into a really long child pose. Okay, so you can come down and be doing some of your child pose stretches. And if you think about where my butt is, I've got one sit bone on this side and one sit bone over here. The space in between is my pelvic floor. So if I'm breathing, I'm sinking basically again. If I'm breathing down through that saddle or down through my genitals, I'm feeling those sit bones come further apart, and that can really help try and get that length through there as well. So again, I could be in just this position, practicing some breathing or that lift and drop. I could go down into my child pose stretches and just taking those 4 to 5 breaths if I'm there. You can add pelvic floor. You don't always have to. You could do this first. My other favorite one is saying, well, can I get some of that pelvic movement? So can I tip? I think of this as like I've got a paintbrush in my bum, and I'm painting stripes up and down the wall. You can pick the color. It's always good to visualize. Think about how much dunking you've got of that paint. Now change your paintbrush, change your color. Can I do circles as well? So I'm getting either big circles, coming into littler ones. Can I go back the other way? And that'll freak your brain out. But it's really good practice to get your brain to be aware that all of these movements are possible as well. You might then relax back down, child pose stretch, or even just coming up into your cat-cow curls as well. Now, this is not a complete sequence. There's lots of resources out there. The Pelvic Pain Foundation have quite a few. I know we've done many series of yoga on QENDO as well, but there can be some really nice ones that you add into your daily sequence. Now, I completely get that in an office environment, you can't get down and do your paintbrushing, but definitely you can do a bit of child pose or leaning against your desk if you need to. Now, I think I've lost all videos here, so I hope you could see me.
Yep.
And we'll go back to a few slides. Thanks, Rosie. And just bear with me because my computer's being an idiot. There we go. Much faster this time. So movement, one of the biggest pillars that we have. Okay. The gut. Now, I'm not a dietitian, but I do talk about poo a lot. The gut is really important for clearing excess estrogen, which we know is a pain sensitizer, and all of other hormones that go through our system. It does have strong links with the pelvic floor. So if there's pelvic floor dysfunction, as I said, it can affect the speed or the transit of the gut, which then can lead to constipation, stretching, IBS symptoms. So fixing the end can actually make a significant difference to fixing the top. And that's not just in pelvic pain, that has been shown in IBS alone as well. So what we want to do is make sure that we're pooing well. So 2 things that I often make sure is that we know how to poo on the toilet. And that picture there is a really nice one. Our hips are higher than our knees are higher than our hips. We're leaning forward. We're not slumped forward, because as we slump, our tailbone kicks in the way. So we're bringing our whole nose and trunk forward over, And again, if we're doing our relaxed deep tummy breathing, I want you to think like your pelvic floor is going to lengthen down into that toilet. And it's almost like you're waiting for that sensation of the water against your skin. Now, that won't happen, but it's definitely a good visual that everything is going to relax. Teaching cooing is a bit of a skill, and it's often something that you've done for a long time in a certain way. So it doesn't take a long time to correct, though, that I find you can do it quite quickly. Toileting when you're doing a poo, it should be relaxed at the back passage. You should have a bulge or widening through your tummy, a bit like you're making a hiss sound or a good old balloon blow. So blowing on your thumb, and that gives that opening sensation at the back passage. So if you're going when you have an urge, you relax when you get there, and you add the correct abdominal bulge, that can really make a difference to what happens on as success. I don't think that you can just change how you poo without also making sure you've got a good formed stool. Now, if it's really soft and runny, and that can happen with pain flares because everything just ramps up, including the gut, so it's like it's a fight or flight into diarrhea, that can be quite explosive and really sensitizing. But often we do get, with a lot of pain medication, poor patterning, poor sleep as well, that we get those harder form stools as well. Now, when you've got a hard poo, it's hard to get out. It strains at that entrance. So making sure you either work with a dietitian or a gastroenterologist, and physios touch on it a lot in this area, that we're aiming for those softer types, because a soft poo and addressing pelvic floor is really important. Now, I've got plenty of patients that I see that their poo type's fine. It's soft, it's like a sausage, but it's really, really thin. And that to me is an indication that that back door is just not opening. If it actually feels like that, and that's the words I use, that if you feel like it's there, but the back door's not opening, that's pelvic floor. And that's how we need to address of what's happening on those muscle sides. Okay. Sleep. I'm not harping on this tonight because our focus was more on the pelvic floor SOS. But if you don't sleep, you don't function. We know that. There's lots of evidence to show that if you get less than 4 hours sleep, and this is not in a pain environment or a pain population, but if you get less than 4 hours sleep in an average adult population, you are 4 times more likely to have immune compromise or get sick. Now, you're also more likely to get sick if you have a chronic pain condition or a persistent pain condition. Pain is an immune response. We don't need to threaten our immune system anymore. So whatever we can do to improve our sleep is really important. If we look at also that average population, if we get less than 6 hours of sleep, so that's actually the average, is that we are 1.8 times more likely to have an injury. Now, what that means is our motor system is impaired. So whether we're an athlete or a social exerciser, the muscle system doesn't fire as well when we're on less sleep. And we've all done that. We've got up in the morning, we walk into the door frame, or we can't open the cupboard, or our system is just not quite there. So we want to make sure that that sleep is helping us from both an immune point of view, but also a muscle point of view. Making a routine is probably the first step. There are some really good resources around. So the Sleep Foundation Australia is a really good starting point. You can also go to bed well. So making sure you exercise not too close to bedtime. So I'm using the word exercise here. So if you're going out and doing your run just before bed, you'll probably notice your endorphins come up. That does make bed a bit harder. You have to have that wind down time. So generally exercise at sundown is fine, as long as you've got then a few hours to recover and get a good routine before sleep. However, movement before sleep can get rid of some of that tension that you've built up during the day. That's also why we've done our body scanning leading into this. And there's some good options here, but definitely not our more breathless, working moderately hard type exercise. I would use things like the Calm app again, or relaxation audios, or even some of the yoga apps that are out there. Now, one I've just written is Downward Dog. I like it because you can set the timer on it. So if you're going to bed, it can do a 7-minute routine. It does a breathing routine at the end of it. So it's a really nice way to wind down rather than have your big exercise component right at the end of the day. So I'm going to open it up here, and feel free to turn. I don't know how this works, so QENDO, please step in if I'm making a havoc out of this. But yeah, I want to hear from you. We're talking flares, so pelvic floor SOS. What's the symptom that you get? What does a flare look like to you?
Can you talk a little bit to the pudendal nerve? Because I hear that come up a lot, and like pudendal nerve issues relating to abdominal, like especially abdominal surgeries around endo and things like that, and what people can do to help with that nerve.
Yeah, sure. Okay. So the pudendal nerve is very superficial. So I'm just reaching sideways. I'll get my pudendal nerve picture out. Here we go. Okay. So the pudendal nerve goes to the skin and it comes out. So here's a vaginal picture. Vaginal entrance, rectal entrance. Here's like my sit bone coming out here. So the pudendal bird has 3 branches, one coming here, one to the top of the clitoris, and one to the back passage. Now the back passage one comes off a lot earlier in the pelvis. So generally it's either this section or this section having symptoms. Most women or most men, either don't have symptoms across the whole lot, but you can. So there's a small percentage where it's the anatomy is a little bit different. Now the pudendal nerve can get injured during surgery, but it can get more irritated is probably a better term. Very rarely is it actually mechanically damaged. It's more that it's been bothered by where it travels between a bony point and a muscle, and it gets either pinched or stretched. And if you think about banging your funny bone, it doesn't like it very much. So if there's constant irritation, that nerve's going to become more inflamed. And the symptoms that you can get from that can be a burning sensation. It can be that vulvodynia type. And if you have pain, you get muscle protection. The muscle protection makes that nerve cranky. So we go round in a circle. Now, I've been talking at that sit bone. So often the relief that we talk about with pudendal nerve is people sitting on the toilet or lying down. And that's because that pointy point is much better. But that nerve travels all the way back to that central point that we were talking about. So anywhere along its path, it can be the glute muscles. Again, it can be the deeper pelvic floor. If you have had deep infiltrating endo and they've gone close to that obturator internus muscle, which isn't always common, again, that nerve could be irritated along there. One of the other common nerves, I'm just going to stand up so you can see my lower hips. So my hips are here. Most people get port sites now with surgery. So we either get one here, one in the middle, or a central one, so 4 sites. There is a nerve that runs along this part here, which is called our ilioinguinal nerve. Now, if you have a lateral port site, it can get irritated or trapped in that scar tissue. So that can cause that burning or irritation through here. Again, sometimes it can be definitely modified because, as I've mentioned, this nerve is irritated. If we can get it to move or de-threaten, so all of those same pillars we were talking about, that definitely can help with a lot of symptoms. Now, I do have some patients where it hasn't made a difference, and there are surgical options, but we do know they have poor success rates generally. But it's a balance of getting, again, your foundations right and getting whatever structures are annoying that nerve to back off so the nerve can relearn not to be so sensitive. Good question though, but it's probably a whole topic on itself. So
no, that's perfect. Thank you. Yeah, I got diagnosed with pudendal neuralgia when I got diagnosed with like PCOS and endo and all of that jazz as well. So yeah. I'm still learning a lot.
So pudendal neuralgia, vulvodynia, I'll put it in for next time. It was definitely one of those things that it's all in this bundle. And the term neuralgia means annoyed nerve. It's not a neuropraxia or a nerve that's been injured. And I think a lot of people search for that injury. And like pelvic pain, we always come up empty on things that are injured sometimes with pelvic pain. And it's just because there's so many things in our bathtub that are annoyed, not particularly just one thing that we can chase. But yeah, it's definitely something that all of these strategies would go towards helping. So
thank you.
Okay. Oh, you're welcome. Should I move on? We'll keep going. Few nods, few thumbs up. Any questions so far? Okay. All right. I'm getting better at this screen change thing, so that's good. We'll be right by next one. Thanks, COVID. All right. So I wanted to touch here because we said, okay, pelvic floor SOS was my topic. Flares, what do we know? I did a lit review at the start of the year as looking into research on endometriosis, and this was in pelvic pain. And the good answer is there's none. So endometriosis and flare research is very limited. What this evidence that I've reported is related to bladder pain syndrome. So if anyone's heard of bladder pain syndrome or interstitial cystitis, so again, that comes under our voiding dysfunction, there could actually be some work on pudendal neuralgia flares, but flares in neuralgias are less common. But flares in bladder pain can be very similar to that of endometriosis. So we are extrapolating a little bit of evidence here. So the MAP network, and you can actually look that up. It's a series of studies if you so wish to look at them. They came out of the, let's say, US. It might be the US or UK, but they were all done in 2019. And these are the first range of studies that are looking at a whole range of patients with bladder pain syndrome, but they're really just asking them lots of questions. There was no intervention yet in this group. This network is going to continue to do those. So when I picked out what they were looking at with flares, the general definition, which wasn't checked by, that's the next arm of the study, by patients or professionals, was that either their bladder symptoms or pelvic pain symptoms are much worse than usual. And that fits in with all of our back pain flare research as well. But a lot of this, keep in mind, the urological symptoms were mentioned because it was a bladder pain population. But these aren't abnormal in also a pelvic pain population. So I do want to make sure that some people have, or get lucky to have both of these. So there is a huge variation in length of flare. It goes from minutes to days to months, and some of the longest flares reported in these studies were 150 days. Now, to me, that I wouldn't really regard that as a flare, but you know, that's kind of half a year. I'd say that that's my baseline level, but people did report that as their flare of symptoms. Interestingly, we come back, the most bothersome is pelvic pain, and it is often what people present with at emergency. We see that. It's the ones that once you've got it, it's a ride out scenario. It's not like constipation or a UTI where things settle it. It's this pelvic pain, and it's the wind up of everything, particularly pelvic floor. So the pelvic pain was the worst symptom, but also the more pelvic pain present was the severity of the flare. To summarize how often people got them, if we look over to the table, they looked at these people over a year. Some people were lucky and didn't have no flares. Now, that doesn't mean they don't have no pain, and it didn't actually quantify if they're in severe or low pain, but they didn't have flares on that. And you can see, though, across the gamut, we're still getting most of the population then having either one or many flares over that time. So it is quite a common phenomenon to have flares. What that means is we need to take the power back out of that. So a flare doesn't mean danger. It's actually, unfortunately, a common problem in pain conditions. It's good to know, and we can put this in both lights, that your age, your weight, your duration of how long you've had your pain and what medication you're taking had very little influence on your amount of flares. There were different subgroups, and this was probably something they're going to piece out a lot more, but when you had more triggers, the pain extended out of the pelvis. Now, this is a term we use, and some of you may be aware of it, called sensitization. And that's where I come back to that nervous system, that the nervous system is continuous. It goes from the tip of your finger to your brain. And this doesn't mean that your brain's not picking up on all the information and processing your history of information, the context, your environment. But it is found that the more triggers that we have, it's when it's more related to the nervous system. So if it's just pelvic floor, usually it's more local factors. But I think it's a very tricky thing to say that it's not a sliding scale, because we know quite quickly you get the nervous system involved with as early as 6 weeks of a pain condition. So if you, in this case, fall over and fracture your ankle, you can have the nervous system changing within 4 to 6 weeks. So it's, of course, a sort of a moot point to say that the nerves aren't picking up and adapting. That's their job. Okay, so to the big one, for all of those that are in flares or suffering with pain, I'm there with you. I understand. I wish we could change it for you day to day, but we are there to try and make this better, and I hope the research joins us as well. So our first pillar of knowledge. Knowledge means, like I said before, that if we're unsure, distress follows. So stress and de-stress are closely linked. But pain is always real. There is pain there. It is your pain. It's different to someone else's, but it is real. But it doesn't mean you're harming. And I guess this is a real hard point sometimes. And I guess where knowledge makes a difference, the research that we have needs to step up to match this as well, that you can be absolutely hurting but not harming, and you are sore but safe. And I guess we want to make sure that you've got a really good full toolkit to pull back on. And I'm not saying that there's not a reason to escalate if you need it, but it is a time and place, because we see so many people manage poorly if we do escalate. And there's sometimes, and I'm sure some of you or many of you have been to emergency and your blood tests are normal, the ultrasound's normal, but you're still in a lot of pain. And I think that needs to be validated, but it means we need something to ride this out. And we don't have great answers completely yet. Hopefully we get there. But we do know that if you name it, you I don't know, call it a name if you really need to, like banana, call it stupid names if you have to, but it does respond to reducing that body's reactivity. So the protective responses of pain, if you name it, to tame it. And you can say, right, I'm in a flare. They're really common. I've seen the studies of those. All right, what can I do? And it's a call to action. That pain is awful, but there are some things I can modify. Now, it might be that your pain gets a little bit better, and it gets a little bit better in 5 hours, or it gets a little bit better in 24, but it's heading in that direction that we want it to. And if you're in control, that's a big step. And this is really hard. This is where I work closely with psychologists and good medical teams that are aware that your pain is real, but give you the support, even if it's just going, look, you've got this. Here are some strategies. Reach out to me, email me whenever you need. Now, to come to the pelvic floor side of this, that muscle spasm, if you've ever had a calf cramp, it's pretty awful. First thing you want to do is swear. Second thing you do is, we ride it out a little bit, but you're looking to try and get some movement in there, because during a cramp state, and as we said, these can last for quite some time, that there's poor blood flow, which irritates those nerves as we're talking. So ischemia, if you've ever lied on your hand and it goes a bit numb and the sensation starts to come back, it's actually a bit achy. So if those nerves have been deprived oxygen, which is ischemia for a while, because of muscle spasm, they can now be more inflamed and achy. And that leads to more pain sensations. If we go back to your fist point, there's inflammation and there's impacts to the surrounding organs. It'd be great if it was a calf cramp, because if you look from your knee to your ankle, there's not much else there. There's calf and a few muscles at the front and a bone. So, or a few nerves. But with the pelvic floor, you can't stop weeing. You can't stop those messages from the bladder or the bowel. So it can't just be taken out of action. And there's many different triggers. So we're coming back to anything in that pelvis. If a bathtub is full, we'll trigger it. So it doesn't just have to be in that pelvis either. So as I've alluded to, the nervous system is continuing. A lot of Okay, I'm just checking because I lost my headphones there for a minute. So
okay.
just decided to drop out. So I did stop talking, so you haven't missed anything. I'll just double check that I've got everyone by a show of hands. So can everyone still hear me? Yeah, cool.
Yep.
Sorry, they just decided to drop out. So of course they do. So let's go back, hey? So this is a tough topic, this one. Okay. So we're nearly there. We'll go back one slide. Okay. So it can be mid-cycle, changes hormonally. It can be a bleed. Again, there's inflammatory changes as part of that. Intercourse, if you poke muscles and poke organs that aren't pretty happy, that won't make them nice either. A UTI, constipation, general infection, it's an immune response. Stress and poor sleep. So all of them, get your pillars right. Keep moving. So muscles don't like being stuck. As I said, your hand, your first reaction is to try and open that hand up. But I'm not talking going for a run. This isn't a marathon. This is going, okay, can I walk? Can I even stretch? If I'm lying in bed because I literally can't move, can I wiggle my toes? Can I move my hands? Can I move my neck forward and backwards? They're all getting input in that's non-painful that you can use. You can use your breathing. Now, that's also something that's non-painful. And I've just mentioned here, it can be in the hot shower. It can be in an Epsom salt-filled warm bath. It could be outside in your favorite spot. Keep breathing. Now, if we think of other pain scenarios like labor pain is not fun either. It's basically, but it is a knowledge base that we know what's happening. So if you know what's happening, it's a lot more easy to feel confident that you're doing something that's supporting that. So breathing, it could be making a sound or using a tissue or moving a pinwheel or seeing a candle move, focusing on the sound moving in and out, alternating nose breathing, something like that. So the focus is now on a non-painful input. Pelvic floor, as I said, it could just be that lift and drop if you're good at it. Generally, I don't do a lot of release techniques in a flare. I just don't find it's all that helpful, but some women do find that either using a warmed vibrator or a TheraWand or a dilator, if you've got them, can actually be quite a nice sensation. Other women prefer cold. So there are some vulval ice packs you can get from Pelvic Pain Foundation. So having those, and particularly our pudendal neuralgia group that someone mentioned, can definitely be used at those times. So ramp up your full toolkit. Heat, ice, lower back heat packs can be really nice as well. General movement, okay, you can't get into the pelvic floor, it's too tense. Okay, what about your shoulders? What about your feet? What about that lower back or the pelvis? Can we inch in to get as much movement that's calm and comfortable? If you can't get out of bed, you can wiggle your toes. You can rock your knees side to side. You could rock your head on the pillow. There is something that we can do that allows that nervous system to wind down, and then we can come closer back to where that cramp is. I mentioned a TENS machine because it's in some of the handouts that I give to patients about flare management and pelvic floor SOS. That a TENS machine can be used. I find you can use it either in flares or maybe it's those earlier points where you can capture it a little bit. It's definitely worth having one that you can try lots of different settings. So there's the Over on the market or just the regular TENS machines that you can change. Something to work with a physio on, but definitely I don't think the expensive ones are needed. I only ever get the ones that you can modify lots of settings. And there's one particularly at Chemist that I don't like because it talks about shoulder, back and neck settings. And it's actually the nervous system. It's not body parts that we're targeting. So save some monies there. Now, this is more a thought page. We've talked about getting in front of flares. This is pelvic floor SOS. You can get movement in some form. We've shown you how to move at the pelvis, how to breathe, how to see if you can get that movement with different cues and which one the best one is for you. But it's also having that toolkit ready. If you cut your finger, you don't call the ambulance. You go, okay, how much blood is there? I'm going to put pressure on it. I'm going to call out for help. Or I'm going to walk because I'm by myself and get my first aid kit out. I'm going to put some pressure on it. I'm going to get a Band-Aid. That's a toolkit. Let's think of this in the same way, that a lot of the time, if you are in a persistent pain state, we can easily rule out some of those infective causes And they can be done with your GP, but you can take control of a lot of the other changes that make as well. So if you know you have certain triggers, can I get in front of them? You can't always predict it, and that's sometimes really hard. But I know I've spoken to several women and they've come in after a flare and they're like, oh, I didn't know what, yep, there's been no cause. And then we've looked at it and there was a car accident 3 days ago. Now, they weren't badly injured, but it was enough that they were rattled and they don't have insurance, and now there's some cost, and they missed a uni exam at the same time. Their neck was a little bit sore because it was quite jarring. They're more tense than they were. And then because of this, they were staying at their boyfriend's house and they missed a few pills. So their period came on earlier than it should. Now, in that bathtub, that's pretty full. There's several things that are adding to that scenario. That means that it might not be something big that happens, but it can be these little things that add up into our bathtub. And our bathtubs are full at the moment. COVID is not helping us. Our stress levels are higher, our situations, our routines are out of order. So we really need to go, well, how can I keep some of these warning signs under control? If you have a pain flare-up, let's think of it like a cut hand. What can I do now? Okay, I'm going to set an alarm on my phone. I'm going to check back in 30 minutes or 5 minutes, however long you want to, because you know you're safe for a period of time and then we can come back to it. Okay. If you have a plan, as I said, some flares go on. What am I going to do now? When am I going to see my GP or my team of support options? How do I build up on this? And it will pass. Now, some flares come a lot, some flares don't. Some last minutes, some last hours. They're all different and they vary between people as well as each time. So just because this is a long one or the last one was a long one doesn't mean this one has to be. So how do I get back into things? I'm not just going to flog myself with a run. I have to build back up. Maybe I do need to do more of my sleep routines and my calming strategies while I give myself the courage to get back out there again.